So, look, it's a pleasure to be able to welcome you. Most of you will know McGann, whose lecture today is going to be on pharmacokinetics guided dosing of hydroxycarbamide, or hydroxyurea, of course, because he's the US. I think you are recently moving or have moved to Rhode Island from Cincinnati, where you now lead both the adult and pediatric hemoglobinopathy program, which is how it ought to be, led by a pediatrician. I have to say it's exactly the same situation as we have at Imperial. Professor Mark Layton was originally doing pediatrics at King's College Hospital before he moved into the other world. We are all aware of your publications, and actually it's very pertinent for here in England, because I don't think in general we have targeted maximum tolerated dose as effectively as has been done in the US, and there are many reasons why that has been the case, but actually I think knowing about the pharmacokinetics may actually help to change how we use hydroxyurea. But in addition to that, all of us have seen your perspective in the New England Journal of Medicine and are very much aware that care for sickle cell disease is not just good pharmaceutical care, but a fight against racism, poverty, and all the additional educational and social circumstances. And so we are as excited to hear about hydroxycarbamide as we are to have your views about the barriers that these patients encounter in their care and actually in life, and we know all the papers that you have written about access to education and academia. And I hope that will be part of what we cover in the questions and answer session. So a pleasure to welcome you, and thank you very much for being willing to give this talk.
Thank you. Sorry, it was not letting me share my screen. Let me see. Share. Okay, can you see my screen now?
Yeah.
Okay, great. So thanks for the introduction. I'm really happy to be here to talk about precision medicine and hydroxyurea. Sorry, I can't remember to say hydroxycarbamide each time, so you'll have to translate for me in your head. But I'll talk a little bit about hydroxyurea overall and talk further about our work with precision dosing. I don't have any disclosures that are related to the work that I'm doing here. So I'll talk certainly a lot about precision dosing, but wanted to give a little bit of a background of hydroxyurea. I think most of you probably already know these things. And importantly, a historical perspective of how we even got to hydroxyurea dosing, and then talk about our work with precision dosing and some future directions, with some time hopefully at the end to hear your perspective. I know there certainly are geographical differences in how hydroxyurea is used, and as you alluded to. So I think most importantly to start is that sickle cell anemia is life-threatening. Organ damage we know begins early. Pain is certainly a hallmark manifestation, but it's much more than just pain. And we've really learned over the last really only 5 or 10 years, really most clearly, that starting hydroxyurea early is beneficial and really should be the standard of care. Here in my own practice, we start hydroxyurea at 6 months of age, with some ideas in my head to start it even sooner, potentially, given that the fetal hemoglobin response seems to be higher when you start earlier in life. But there should be no patients with homozygous SS disease who are not treated when we have a good treatment like hydroxyurea. So sickle cell disease, as most of you probably know, was discovered or first reported over 100 years ago, 1910. There really were no disease-modifying therapies until hydroxyurea was discovered, as we'll talk about in about the 1980s for sickle cell disease. These disparities, as was alluded to in the introduction, are probably very significantly related to the demographics of sickle cell patients, where the scientific advancement was not really prioritized. The novelty of discovering sickle cell disease and calling it the first molecular disease, as Linus Pauling did midway through the 20th century, was good for science and good for publications, but there were no efforts really to develop treatments. There were blood transfusions, there was penicillin to prevent infection, there was folic acid, which really still has pretty little evidence that it improves sickle cell lab values or clinical care at all, and then really hydroxyurea. And now we're excited to have new therapies on the horizon, including gene therapy and other potentially curative therapies, but I think while these things are being developed, we really need to be good about using hydroxyurea early, often, widely, aggressively. There's many different ways to potentially treat sickle cell disease. Starting at the top by preventing polymerization of sickle hemoglobin is the easiest place to start. Fetal hemoglobin, we know from the physiology of infants and the physiology of those who inherit hereditary persistence of fetal hemoglobin, is protective against polymerization of sickle hemoglobin, and has been a holy grail of treatment for a long time and remains so. While we know what hydroxyurea does, there are many other efforts, including gene therapy efforts, to induce fetal hemoglobin. So we know that if you have a high level of fetal hemoglobin, sickle cell complications are prevented. This is in contrast a bit to some of the new mechanisms of action, like shifting the oxygen dissociation curve or affecting pyruvate kinase or other aspects of red blood cell metabolism, where we don't really know what the impact on sickle cell patients may be, but we really know what fetal hemoglobin does, primarily through these experiences. So hydroxyurea is an oral once daily medication. It was initially used as chemotherapy much before the time it was used for sickle cell disease, and it really, hydroxyurea has a hard time shaking that negative connotation, which is a bit of the problem in terms of its widespread uptake, although hopefully we are getting beyond that. It was the first FDA and EMA approved drug for sickle cell disease. We know that it raises fetal hemoglobin. It's well tolerated, but still is probably significantly underutilized. We know the laboratory benefits. It raises hemoglobin, it raises fetal hemoglobin. The blood smear is improved, as you can see on the right, and it improves basically every sickle cell complication that you could see: pain, acute chest syndrome, transcranial Doppler velocities, number of transfusions, mortality in high and low income settings. So it's really about as good as we're going to get right now. So before we get into the pharmacokinetics discussion, I wanted to kind of give a little bit of a history of the early hydroxyurea studies, and especially around dosing, and how we got to where we are now, where we have a pretty standard dosing regimen, which maybe shouldn't be so standard. So the first studies of hydroxyurea in humans with sickle cell anemia was in 1984, work by Ora Platt and his colleagues in Boston, where they treated two patients. You note the dose, 50 milligrams per kilogram per day, divided into 3 oral doses, which is much higher, almost double, more than double the dose that we give these days to many patients. And it showed that it increased fetal hemoglobin. And issues that were discussed in this publication 35 years ago were, how does hydroxyurea really work to increase fetal hemoglobin? What's the right dose? How often should we give it? What are the long-term risks or benefits? And even though we know a lot about hydroxyurea today, 35 years later, these questions are still pretty relevant. So continue, the doses are still quite high a couple years later, 50 milligrams per kilogram per day. It really showed a rapid and robust increase in fetal hemoglobin. There was toxicity in one patient who had a suppression of his reticulocytes and needed a transfusion. Renal function was noted to be important on fetal hemoglobin response, which was related to hydroxyurea dose and exposure. They did PK studies at this point, again, 35 plus years ago, and they showed that there was lots of interpatient variability, and they demonstrated a clear relationship between how much hydroxyurea your body is exposed to and what the response was, which makes sense, but I feel like these early studies got lost for some decades thereafter. In this paper, the quote, again, very prescient 35 years ago, that careful adjustments of hydroxyurea dose based on measured plasma levels after a test dose, this is exactly what we're doing in our PK studies today, may permit a more selective effect. Again, these are very good ideas in the 1980s that seem to have been lost. These were patients that were treated for a longer period of time, and again showed that they used pharmacokinetics to look at hydroxyurea response. and they showed great variability, and they again noted that individual pharmacokinetic studies might be necessary to adjust the dosage. So the ideas that we're doing now are really not too novel. This is another paper where they got a little bit more aggressive with the dose, where the idea of maximum tolerated dose, MTD. So the initial dose was based on the area under the curve and then escalated to maximum tolerated dose, which is again exactly what we're doing in the studies that I'll talk about in a little bit. Doses ranged from 10 to 35, so threefold difference in the dose, milligrams per kilogram per day. The fetal hemoglobin response, the pharmacodynamic effect, again, as we still see in our patients today, was highly variable. And they saw that virtually all patients on the right side, you can see before and after hydroxyurea had increases in their fetal hemoglobin response. This publication noted that really the only ones that didn't respond were those who were non-adherent. There's many believers of quote unquote non-responders to hydroxyurea, but I don't really think that's a thing. I think it's there's really two reasons why one doesn't respond to hydroxyurea. One, or doesn't respond sufficiently. One is you're not taking the medication as prescribed, or two, the dose isn't high enough. I think if you can work on both of those factors, then everyone is a responder. So the definitive phase 3 study that led to the ultimate approval was the multi-center study of hydroxyurea. This was randomized to placebo in 300 adults with sickle cell anemia SS disease. The dose started at 15 milligrams per kilogram and was escalated based on complete blood counts until the neutrophil count was less than 2,000. The study was stopped prematurely because hydroxyurea was so effective. In this study, the figure on the right is important. This is the final dose at the end of the study for the patients, and you see the variability from not a small number of patients who had doses less than 10 milligrams per kilogram to many who had doses greater than 25 or 30, or even 35. The speculation is that many of those who had the highest dose prescribed might not have been truly effective. Again, the conclusion of this study, which again was lost for some decades, was that dosage and dose schedules should be studied further. Instead of studying the dose further, at this point, really we got FDA approval, and the doses were based exactly on this study, 15 milligrams per kilogram per day starting dose, and then escalating. And I think, unfortunately, this really led and continues to lead to many patients being underdosed. This paper from 1997 was relevant to, it really is relevant to the differences in children and adults. And this noted clearly that many adults don't really tolerate as high of a dose. They have much more toxicity. And they noted here, and I think we still think today, that this is because really of bone marrow exhaustion is the word I use. Potential bone marrow scarring, where just small doses of hydroxyurea result in cytopenias that limit the dose. But they note here again, very insightful at this time, was that starting very early in life, before the marrow or other organs are damaged, is likely to be more effective, and it is, as you'll see in the data we showed today. So FDA approval, as I mentioned, happened in 1998 with doses really directly from this study, 15 milligrams per kilogram, escalate. You see the doses related to renal function. If you have impaired renal function, the dose is 7.5 milligrams per kilogram, which is really not going to be enough to have a significant clinical benefit. So from these adult studies, we knew that it improves fetal hemoglobin. We saw that the doses are highly variable, but also importantly, early on, it was noted that hydroxyurea exposure, as defined by area under the curve, is clearly linked to the clinical and laboratory efficacy. The chronic organ damage of untreated adults with sickle cell disease affects the dose and certainly augments the clinical response. And even now, 35 years later, we still need to better understand this. For the pediatric people in the audience, you'll be familiar with the Baby Hug study, which was the randomized placebo-controlled phase 3 study in children, young children, 9 to 18 months of age at enrollment. And this had no clinical severity criteria. The MSH study required certain numbers of pain episodes or acute chest syndrome. And this study just took infants who were otherwise quote unquote healthy with a diagnosis of sickle cell anemia and randomized them to hydroxyurea or placebo. The primary outcome was looking at organ function, which was not achieved for a variety of reasons, but the other clinical endpoints, pain and all of the things we know about transfusions, lab values all got better, and again showed that this is effective and probably should be the standard of care in young children. So really the MSH and the baby hug study led to these guidelines from our U.S. National Institutes of Health, or National Heart, Lung, and Blood Institute, NHLBI, in 2014. And these are important guidelines, but maybe are a bit misleading. They're really just strictly based on the studies. And so you see number 2, treat adults with greater than 3 pain crises in 12 months. But number 6, offer hydroxyurea to all infants and children, regardless of clinical severity. And again, this is really just directly using the criteria for these 2 phase 3 studies, but the recommendation really is use hydroxyurea in all patients. There's no reason why you would wait to have 3 pain crises before starting it in an adult. The dosing guidelines from these recommendations, again, weren't super creative. They were based entirely on the clinical trials that I mentioned. And again, I think this is probably a bit too conservative. There was discussion of dose escalation, but with caveats, and I think in real world, many patients just sit at a fixed dose, and dose escalation probably doesn't happen as well as it should. So we have these guidelines, and therefore everyone in the US takes hydroxyurea, right? No. So you see on the left, this is a study from just 5 years ago. The dotted line is the SS patients. This is, and the y-axis ends at 40% at the top. So less than 50% of children with SS disease are prescribed hydroxyurea. We're probably a little bit better now, 5-7 years later, but certainly not to 100%. In adults, the figure on the right, the blue line is use of opiates, and the yellow line is use of hydroxyurea. And again, this is problematic. Only a fraction of adults with sickle cell disease are prescribed this very effective medication. So this is related to a variety of factors, not excluding access to good care, trust in medical providers, things that, again, that were alluded to due to the just general challenges of race in medicine. But also it's due to dosing, and if you're using ineffective dosing and it doesn't work, then patients aren't going to want to take it and providers aren't going to prescribe it as often. So it's very multifactorial, but we really need to do better. So reasons why we probably aren't using it as much. The chemotherapy tag has not gone away. I think we're a little bit beyond that. If you were a patient in 2002 and were described, or 1990s, and heard about hydroxyurea, you probably heard about it, that this is a new medicine, it's chemotherapy, we only will use it if there's lots of problems. And and then in those patients' heads, they were afraid of hydroxyurea. They didn't want to take chemotherapy. They don't have cancer. They don't know what the long-term effects might be. And then now, fast forward a decade or 2 later, we're using it in all patients because we have more evidence, but those initial thoughts are very different. And so we now discuss hydroxyurea early in life, at the first visit for our pediatric patients, and describe how we plan to start it early in life and how we now have decades of evidence showing how safe it is. And I put Google on the right, and so if you type in does hydroxyurea, Google finishes all these terrible things. It does not say does hydroxyurea help sickle cell disease or decrease pain or whatever. It's all negative things, just showing you how people use Google most frequently. But I address these things because these are what the patients are going to look at for my sickle cell and other patients. You want to address their concerns and be transparent about it so that they can develop trust in what you're saying. Another explanation, again, is this sort of vicious cycle of if you're using a low kind of wimpy dose of hydroxyurea, the effects aren't going to be that good. And if the effects aren't good, the patient's not going to want to take it. And if the patient comes back and says the effects aren't good, the providers are not going to believe in hydroxyurea, and then it's not used as often. I think if we start early in life and we use good dosing and keep that dosing up and work with the patient on adherence, then we can do a lot better. So I have started a new position here at Brown University in Rhode Island, but I was in Cincinnati for about 7 or 8 years, and I'm not saying this was the direct effect of my mentor Russell Ware's presence there, but you see the blue line, that's younger children. The other lines are different age groups, but the use of hydroxyurea dramatically improved, whereas less than 50% of, I think, the under 5 patients were taking hydroxyurea in 2014. As of recently, virtually or not virtually all of them, are taking it because we shifted the reference, the discussion around hydroxyurea. Not surprisingly, the use of hydroxyurea, as the use increased, the clinical complications decreased, again emphasizing that the medication works not only in clinical trials but in the real world. So we talked about this. The conversation needs to be different. The conversation needs to be that this is the standard of care. The same way that if you have diabetes, you use insulin. If you have asthma, you have inhalers that you use. This is the standard of care. Everyone should take it. This is really what is necessary and should be started early and should be used for all patients, regardless of what their clinical manifestations might be. So I'll talk a little bit about a lot about precision dosing and pharmacokinetics and some of the work we did to look at this carefully. And so, as was noted by the very, very early studies 35 years ago, there's tremendous inter-patient variability in the pharmacokinetic. So that curve on the left shows two types of patients. This is the y-axis is the hydroxyurea concentration and the x-axis is time. And so you see there are some patients who are labeled here as the fast phenotype who absorb hydroxyurea very quickly and subsequently eliminate it quickly. There are others who absorb it a little bit more slowly. These phenotypes are probably not quite as binary. If you just looked at a bunch of patients' pharmacokinetic curves, they would be all very, very different. But these absorption patterns and these pharmacokinetic profiles have significant impacts on dose. And we know that dose affects clinical outcomes. And so it doesn't make a whole lot of sense to treat everyone the same. The pharmacodynamic response, as defined in this middle curve by fetal hemoglobin, as you know, and who, for those of you in clinical practice who take care of sickle cell patients, the fetal hemoglobin for some patients might struggle to get into the teens %, whereas others might have fetal hemoglobins of 20, 30, 40%. And again, this is all very clearly related to hydroxyurea exposure. Dosing, as noted in the early studies, and again in clinical practice, can range in some adults who can only tolerate about 10 milligrams per kilogram to other younger patients who can tolerate 30 or 35 milligrams per kilogram. Maximum tolerated dose, this curve shows that it takes a long time to get there. If you actually look at blood counts and increase them, these are from a combination of clinical trials that show that it takes 6 to 12 months to get patients to maximum tolerated dose. Requires a lot of blood draws, is kind of tedious for the patient, tedious for the provider. And I think because it requires effort, many times patients are just started at a dose of 20 or so milligrams per kilogram per day and then are just left there. And for our pediatric patients who grow and change the denominator of that equation as kilograms, that dose becomes less potent over time. So the initial questions, this is now 7 or 8 years ago or so, was whether we could do precision dosing. At the time and still now, precision medicine and individualized dosing was becoming in vogue, and we wondered if we could maybe do this with hydroxyurea. And really what the initial hope or hypothesis I had is that if you could start a patient at the right dose, you wouldn't have to do all of the dose escalation and wouldn't have to have blood counts to escalate to maximum tolerated dose. And so that was the initial idea, and you'll see how that turned out. And we really, because this was happening primarily in children at the time, we wanted to develop an approach that was not just a research study, but a way that might be feasible in the real world, in the clinical setting for these young children. So traditional PK studies in many clinical trials involve full days getting venous blood drawn very often, and that just wasn't going to be practical. So we wanted to do it in a practical way. So the first study was called the Therapeutic Response Evaluation and Adherence Trial, or TREAT, which was a single center open label trial of this individualized dosing strategy at Cincinnati Children's Hospital. And the goal, the objective at the time, was to come up with a model and to individualize the dosing using pharmacokinetics. And the objective was to reduce the time it takes to reach MTD. The objective was not, at the time, that this dosing model would be better, but that it would be more efficient at getting to the right dose more quickly. So how do we do it in a practical way? And so we knew from historical data from a group of patients who were at clinically defined maximum tolerated dose, that their hydroxyurea average area under the curve, or AUC, was about 115 milligram hours per liter. There was certainly variation, but this was the mean number. And so we targeted this. We wanted to get patients to that area under the curve. And so the plan was to give a patient a dose, a 20 milligram per kilogram dose. And we wanted to do this, again, feasibly in young children. So the picture on the left shows a little collection device where you just have to do a finger stick of the finger or toes in some of these babies is what was more convenient, and take a drop of blood that absorbs onto that tip of that device, 10 microliters of blood, and then analyze these samples. Ultimately, we did this by LC-MS and measure hydroxyurea concentrations and incorporate this into their peak to create a PK curve. You see on the left this bottom curve that we saw earlier of the different phenotypes. We were trying to come up with a time frame of collection that would capture points on before the peak and after the peak of hydroxyurea exposure, and we thought that somewhere around 3 hours, we needed samples at least 3 hours out, and so we decided that collecting samples at 3 time points, 15 minutes after the dose, 1 hour after the dose, and 3 hours after the dose would give us a pretty good idea. We could incorporate those values into a population pharmacokinetics model based on, again, a larger cohort of historical patients to create pretty good PK curves for each patient. So this is what it looks like in a patient example. And so on the y-axis is hydroxyurea concentration. The x-axis is the time after the dose. So on the left, this is a patient who received a 20 milligram per kilogram dose of hydroxyurea. The blue circles are the hydroxyurea concentrations. And using those 3 blue dots, those 3 concentrations, and the population pharmacokinetic model, this is what we hypothesize, or we estimate the PK curve looks like for this patient, which would come up with an AUC, an area under the curve, of 84.5 with this 20 milligram per kilogram dose. We want to get the patient to an area under the curve of 115, and so using the pharmacokinetic model, the software, for this patient, we estimated that a dose of 250 milligrams or 27.8 milligrams per kilogram per day would get that patient to the target AUC. And so instead of starting at 15 or 20 milligrams per kilogram, we would start this patient at this pharmacokinetic guided dose, significantly higher, 30–40% higher than the initial weight-based dose. So in the first 50 patients in this TREAT study were, as you would expect based on our clinical use, many of them were very young. A majority of them were less than 12 months of age. Although there were 14 patients who were older than 24 months of age, just giving a spectrum of ages within this cohort. I highlight fetal hemoglobin level, so you see that the starting fetal hemoglobin level of 31% was pretty high for these young babies, as would be expected before the fetal hemoglobin switch is complete. Also, you note that the reticulocyte count is high, even though these young babies are pretty well, showing that, again, not unsurprisingly, the manifestations of sickle cell anemia start very early. So these patients had hemolytic anemia that probably was damaging their internal organs at the time, which again supports early use of hydroxyurea. I also highlight the absolute neutrophil count at the bottom. And again, before these patients become so inflamed with sickle cell disease, the neutrophil count is not too high. And so many dose escalation strategies will use a target ANC of less than 3,000 or so, or maybe 2,000, 2,500. And so if the ANC is already less than 3,000, you're never going to be able to increase that dose. So if the starting dose is 20 milligrams per kilogram and you would only escalate if that ANC was high, then you are going to never budge from that 20 milligrams per kilogram dose. And so for us, we started at a higher dose, giving, again, more hydroxyurea exposure. So for these patients, the starting dose was high. The recommended starting dose was over 30 milligrams per kilogram per day. Some of them were 40 or 45. We were bold, but not that bold at the time. We didn't use any doses above the recommended maximum dose of 35 milligrams per kilogram. So the actual starting dose, bringing down some of those high recommended doses, was about 28 milligrams per kilogram per day. you see that a majority of them, 47% of them, were greater than 30 milligrams per kilogram per day. So at the beginning, when we were taking these 9-month-old, 9-month-old babies and who were unaffected and their ANC was 2,000 or 1,500, and just giving them 33 milligrams per kilogram per day was a bit unnerving, but we've become much more comfortable with that over time. So the starting doses were high, significantly higher than what we would typically use, but they were safe. There was no increased toxicity. The starting dose was the MTD. We didn't need to change the dose for 82% of patients. The primary endpoint, which was the time to get to maximum tolerated dose, was shown in the curve on the right. I said it takes 6 to 12 months to get there traditionally, and we got there much sooner, almost immediately, basically, for most patients using this dosing strategy. But much more excitingly, the responses were phenomenal, beyond what we would ever have thought. So for those of you who are familiar with hydroxyurea response, typically a fetal hemoglobin level above 20% is considered a pretty good response. Above 30 is phenomenal. Above 40 is usually unheard of. Just as a comparison, there are gene therapy trials that are trying to induce fetal hemoglobin, and if they were able to get 30 or 40% fetal hemoglobin using these strategies, this would result in pancellular expression of fetal hemoglobin and would be considered a success. And we had that for most patients. So 64% had fetal hemoglobins above 30, 43% had fetal hemoglobins above 40%, which was really quite exciting. So I mentioned pancellular fetal hemoglobin. So fetal hemoglobin, when you get a typical fetal hemoglobin level, that is a percent of total hemoglobin. So a fetal hemoglobin of 30% means you have 30% fetal hemoglobin and 70% or 67% hemoglobin S and maybe a little bit of hemoglobin A2. But it doesn't mean that all of your red blood cells are protected, or even that that percentage doesn't mean much. So the concept of F cells and heterocellular or pancellular expression of fetal hemoglobin is becoming a bit more used in both clinical practice and research studies, especially some of these curative therapies. And really, we hope for most red blood cells to have enough fetal hemoglobin in them to protect against sickling. And this pancellular, really, if you're above 70 or certainly 80 or 90% of your red cells having hemoglobin F in them, it's considered a pancellular expression. And we saw that, again, that the target for these curative therapies is a total fetal hemoglobin of 30% and more than 70 or 80% F cells. And over time, virtually all of our patients had that. And we found that the 70% F cells and 30% fetal hemoglobin sort of matched up. So if you don't have access to F cells, the target really shouldn't be 20, but it really should be above 30% fetal hemoglobin to have the most protective effect. So one of the questions, because these were young children, was whether or not this fetal hemoglobin expression would be maintained over time. The fetal hemoglobin or this hemoglobin switch physiologically occurs in the first 2, 3, 4, even 5 years of life for some patients. And so we wanted to get through that time and show that the fetal hemoglobin increased. These are 3 examples of many that show. The one in the middle one is probably the best one. So this patient started hydroxyurea at 9 months. At the time, the fetal hemoglobin level was just above 20%. With hydroxyurea, the fetal hemoglobin went up to above 40, and now the child is 6 years old, or a bit older now probably, and that fetal hemoglobin is still 40%. So this is well beyond the physiologic hemoglobin switch. These other graphs show similar things. The one on the right shows that an older patient whose baseline fetal hemoglobin level was less than 20%, close to 10%, was still able to get a fetal hemoglobin close to 40%, showing that you can do this not only with the very young children, but also with children of older ages. So TREAT was important. It showed us that not only was PK dosing feasible and reduces dose titration as we had hoped, it also seems to be maybe more effective than weight-based dosing. The confounding factor was that most of these children were very young, and this is really one of the first large groups of patients that had hydroxyurea started with aggressive dosing starting really early in life. And so, we weren't sure with the single-arm study whether these results were because the PK dosing model was so robust, or because just starting hydroxyurea at an early age is beneficial. So this has led to a subsequent study that's still ongoing called the Hydroxyurea Optimization through Precision, or HOPS study, which is looking at comparing the treat model, basically PK-guided dosing, to weight-based dosing at 13, now 15 sites across the US. This also will assess the feasibility of doing centralized PK processing to see if this could really be a clinically useful thing, and we think it can be. We also are looking at the gene expression, silencing, trying to understand how early use of hydroxyurea impacts the hemoglobin switch, and whether there really is scientific evidence to support early initiation well before the fetal hemoglobin has been silenced, which I think we have evidence for that. So HOPS is ongoing. We're about 75% enrolled, and hopefully we'll have some answers. And frankly, I don't feel I'm a proponent of PK-guided dosing, but the other arm of this study uses 20 milligrams per kilogram and then pretty aggressively escalates that dose over 3, 6, 12 months. And so even if PK-guided dosing isn't any different, I expect that starting early and being aggressive about dosing is equally or close to equally as effective. And so even if you don't have access to PK-guided dosing, which most don't, starting hydroxyurea early and really paying attention to that dose is critically important. So in children, what do we know now? We know that you shouldn't wait for symptoms. You should start hydroxyurea early. I recommend starting at 6 months of age, or certainly before the first year of life. We have enough evidence now, I think, through these studies as well as studies done globally, and including the recently published, or last year, no harm study from my mentor Russell Ware and his colleagues in Uganda, where they showed that a starting dose of 25 milligrams per kilogram per day was superior to 20. So I think even in the absence of PK-guided dosing, I think that our starting dose should be higher than 20 milligrams per kilogram. Maybe PK-guided dosing is better. We still have things to learn about that. Certainly, one size fits all is not the right approach, and paying careful attention to dose and dose response is critically important. Dose escalation is important based on blood counts, but equally important in pediatrics, which I think is often lost, which we're pretty aggressive about, is adjusting for weight gain. So especially young children, when we're starting children at 6 or 9 months, their weight exponentially grows over the course of months or years. So a dose of 20 or 25 milligrams per kilogram can quickly become a dose of 10 or 15 milligrams per kilogram if you don't adjust it. So for us clinically, every single visit, we bump the dose a little bit by 20 or 40 milligrams to maintain the same milligram per kilogram dose, so that we maximize effect. Even if the labs look good, as long as there's no toxicity, we keep bumping that dose just to keep the hydroxyurea exposure really as high as it could be. We still have barriers to the optimal use of hydroxyurea, barriers that are on us as providers, which is related to dosing, and barriers that are on sort of the whole team, including the patient and the providers, to work on methods to improve medication adherence. So a couple of future directions. So the work that we've done so far is exclusively really in children. And so children, as you know, as I showed, tolerate really high doses of hydroxyurea pretty well. The clinical benefits are great. The fetal hemoglobin responses are robust. For those of you who don't care for children or who are adult providers, you probably are saying this doesn't apply to me. My patients can barely tolerate any dose of hydroxyurea, and this is probably true, at least the adults right now. I do think that our children who are starting hydroxyurea within the first year of life and are maintained on it throughout life are going to become very different adults. And I think that I would hope that that slide I showed a couple times ago of this 6-year-old with the fetal hemoglobin of 40%, if that child continues to take their hydroxyurea, I expect them to be a healthy adult and still to tolerate a high dose when they're older. But right now, our current adult population has had mostly a lifetime of not being treated and allowing for chronic organ damage in their kidneys and their bone marrow to develop that has significant impact on the amount of hydroxyurea that's able to be provided. The fetal hemoglobin responses, again, really related to the amount of dose that you can get into the patient, are not as robust in children. It's not as robust in adults as in children. And because adults are more likely to have toxicity, I think many providers are pretty cautious and probably too conservative in dosing because they want to avoid toxicity. While children receive doses of 30 milligrams per kilogram easily, many adults probably receive, a fraction of that, and not, therefore with low doses and low hydroxyurea exposure, the fetal hemoglobin response, the clinical benefits are not quite as good, which again leads to kind of a whole cycle of negative connotation to hydroxyurea. So why is it more challenging in adults? We sort of talked about most of these. I think many adults were introduced to hydroxyurea when it still was a bit experimental and when there were concerns about it being chemotherapy and not knowing about long-term side effects. And so again, it's re-educating patients about what we know now. These doses we sort of talked about, and I think that while we're probably not going to get the results in adults as we did with the studies I showed in children, I still think we can be better if we individualize dose, because not all patients, not all adult patients are going to have problems, and many of them could probably tolerate higher doses of hydroxyurea if we thought carefully about it. So there's an ongoing plan to individualize dosing in adults with sickle cell anemia, but we sort of have to start at square one, which we're doing. I mentioned that the pharmacokinetic profile of children at MTD showed that the area under the curve at MTD was about 115, and for adults we don't really know what that target is, and so we don't know how renal function truly impacts this. There's the table that's in the FDA guidelines showing that if someone has renal impairment, to use a lower dose, a significantly lower dose, but we probably could be more careful about that and try to tailor doses based on some of these things. Bone marrow reserve, defined as their baseline blood counts and baseline neutrophil reticulocyte count, platelet count, will probably impact how much hydroxyurea they tolerate, but these are not incorporated into dosing. And so I think the model for adults is going to be much more complex. So we are currently studying a cohort of adults who are on a pretty good dose of hydroxyurea at what appears to be the maximum tolerated dose, and we're going to carefully investigate their pharmacokinetics, their renal function, their bone marrow parameters, their response, to get a sense of how all these things interact, and we'll develop a model. The goal is to develop a model probably more complex than the one we have for children that incorporates some of these things like renal function and baseline blood counts to individualized dosing, so that we can be informed as to how much a patient may be able to tolerate. Again, making it easier instead of this sort of conservative dosing strategy that seems less effective than it could be. So in the last couple of minutes before we can hopefully have some discussion and questions, I wouldn't have a talk without talking about the global burden of sickle cell disease. So as most of you know, sickle cell disease is a global problem. There are more than 300,000 infants born with sickle cell disease every year, 90% of them in sub-Saharan Africa. As a comparison to global health problems, there are more infants born with sickle cell disease each year than children diagnosed with HIV. However, huge disparities in sort of attention and funding to these issues. Newborn screening, which is life-saving in high-resource settings to identify sickle cell disease and provide treatments, is not available outside of most high-income settings. Hydroxyurea is mostly unavailable for a majority of children that live in sub-Saharan Africa. And even if it's available, it's not used very widely. There is emerging data from several studies, including the REACH study, No Harm that I mentioned, a couple of studies in Nigeria, SPIN and SPRING, that are really proving or reproving the safety and benefits of hydroxyurea in patients living in sub-Saharan Africa. However, because again of all of this notoriety that it's a chemotherapy medicine, that it suppresses your bone marrow, that you need to do blood counts frequently, is kind of intimidating for many providers or healthcare systems in low resource settings, and there's not a whole lot of effort to try to bring hydroxyurea to many places because it seems like it might not be feasible. If you need to do blood counts every month or 2 or 3, then forget it, it's not going to happen. Or if hydroxyurea might not be safe in the setting where infections are possible, then maybe it shouldn't be used. But I think we're hopefully getting beyond that. Dosing becomes another issue. I think because of these concerns, there are some people that believe that we should use low dosing. There are some that say that 10 milligrams per kilogram is enough to appease sickle cell disease, basically to cause a little bit of a benefit. That argument is also used to say, okay, there's not a lot of hydroxyurea in Africa, so we should use a lower dose so that we can give it to more people to basically ration a low supply of hydroxyurea, which is, I think, a crazy and very inequitable rationale. I think we should make it available to all and use it at the right dose, but we need to find what that right dose is. PK-guided dosing, like we talked about, might be impactful, so we could find the right dose, set it and forget it for these patients, and we're going to try that. We have a new study that's going to start soon in Angola and Tanzania called the Pushup study. If you haven't noted by now, all studies have to have a good acronym, so the promoting the utilization and safety of hydroxyurea using precision in Africa, Pushup, will look at 2 things. One is trying to replicate what we did with PK dosing in the US. You see that yellow box in that picture on the right, that's an HPLC machine that is sort of built for low resource settings, that's modular, so if something breaks, you pop it out and put another piece in. We'll see if this is truly practical to do this in low resource settings, to be determined. And the other objective of this study, which I think is probably more important than the PK-guided dosing arm, is the plan to use hydroxyurea with very limited laboratory monitoring, basically no complete blood counts, just look at hemoglobin every 3 months and clinical outcomes. In the REACH and other studies, we've found very, very few cytopenias, and when we see them, they are not clinically relevant. So if you check and you find a neutrophil count of 500, you stop hydroxyurea and the patient is fine and it gets better and you resume it. But I think checking a CBC is a barrier, and these cytopenias are so rare and I think not clinically relevant that in order to truly widely make hydroxyurea widely used, we need to clarify this issue of whether laboratory monitoring is needed. I think that it isn't, and that's what we're going to look at in this study. So in summary, hopefully with a little bit of time for questions or discussion, hydroxyurea really should be the standard of care for all patients with homozygous SS or S-beta-0 thalassemia, starting very, very early in life. If you start early, you probably can get a much higher fetal hemoglobin level if you can maintain a high dose and ensure medication adherence. The situation in adults is certainly quite different because of organ damage and decades of untreated sickle cell anemia. Individualized therapy and being careful about pharmacokinetics and individualized dosing might allow for optimization for children, for adults, for people living in low resource settings, but still a lot to be learned. Thanks. I'm happy to have discussion, conversation, or have.
Thank you very much, Pat, for that great overview and insight into how we might use hydroxyurea more effectively. Can I just kick off the questions by asking you to what extent the basal steady state hemoglobin F level in patients predicts response to hydroxyurea?
So it's really the only thing that's been shown to the ultimate fetal hemoglobin response is very much determined by the baseline, but you can still take patients with a fetal hemoglobin of 2% and get them to 35. It's probably easier to get someone who has a baseline of 15 to 35. But I don't think I think that it's possible with the right dose to get all patients to a reasonable level. And I don't think you should ever, before the study, I think it's used less so now, but some people would use once you get to a fetal hemoglobin level of 20, they would stop, escalating the dose. They would sort of be happy there. But I think we should really truly maximize the amount, because the more the better. But so yeah, long answer, the baseline fetal hemoglobin does significantly affect it, but you can get there, I think, regardless of what that baseline level is.
And just supplementary to that, do you have any guidance on thresholds in terms of hemoglobin increment where you might become concerned at the increase in hemoglobin in patients on hydroxyurea?
Yeah, this has become a bit more discussed because of voxelotor and other hemoglobin raising medications. I don't really get too concerned. In our patients, many of these young patients will have hemoglobins in the 10 to 12 range, which are perfect. None that get too high, like we're seeing with voxelotor a little bit, 13, 14. I think that the concerns, and this was recently written by someone, I forget whom, the concerns with hyperviscosity in this kind of magic number of 12 or 12 and a half is a bit historical and really related to a different, a fetal hemoglobin of 12 with 40% fetal hemoglobin is a lot different, I think. So I don't really have concerns. I haven't had any patients that I've had to back off because they had too high of a hemoglobin.
Thanks very much. I'm sure there'll be some questions from others in the audience. Would anyone like to raise their hand? Question from Justin Harrison.
Thanks very much. That was very, very excellent talk. I don't have a very big sickle cell practice at all. I think I've only got one patient, but I do use bucket loads of hydroxycarbamide in myeloproliferative disorders. And one of the things that I see, particularly with prolonged use, is very high incidence of skin cancers, SCCs and BCCs. And I wonder, you have not really spoken about the long-term side effects of hydroxyurea, and I wonder if you would comment on that, because it sounds like some of these people are going to be on it for 50 plus years or longer, you would hope.
Yeah, it's a good question. So I think we have, there's certainly some patients who've been on it probably for 20 plus years or so, and there's unfortunately not a great long cohort. It used to be that whenever there was a case report of a person with sickle cell who got any sort of malignancy, it was described and there was question of whether it contributed, but there's no signal towards that now. Sickle cell patients, as you know, get leg ulcers, and there's concerns in other diseases of hydroxyurea contributing to skin findings, but none that we've seen, or no signal that seems significant at this time. And when patients talk about this, even though there's still a bit of an unknown, I think that the risk for long-term complications such as malignancy seems quite low, and the benefits, and still unknown, and the benefits are so high that even if there were some yet to be described low risk, I think that it would not be high enough to withhold hydroxyurea. So I think we still have a lot to learn. There's certainly unknown questions about, there's a lot of controversy about fertility in the long term, and there's not great control groups. Untreated sickle cell disease causes decreased fertility or ovarian reserve or sperm function, and we hopefully will see. I suspect that these young kids who are treated from early in life, who have a fetal hemoglobin of 40% their whole life, will be basically healthy people, but it still is to be determined. We need to have good long-term follow-up studies, which sometimes are difficult to do, but I think the answer when patients ask me about long-term complications, is there none that we know of yet? We're still monitoring, and I think if there were significant signals towards this, we would have seen it by now, and we just really haven't.
Pat, I guess the mortality data is very reassuring as well, isn't it, in long-term hydroxyurea use?
The mortality has been shown in long-term studies in the U.S. and Belgium and Brazil and Africa, and so it clearly prolongs life. And these are in cohorts of patients who started it very late in life. And I would presume, again, that these young patients are going to live a very different adult life than most of the patients who started at 15, 20, 25 years of age.
And question from Asad Lukmani.
Thanks very much for a really excellent talk. One of the questions I was going to ask is about fertility, but I think you've kind of touched on that already. That tends to be a big issue in adult patients who refuse to start hydroxycarbamide. Another question I just wanted to ask is, what you were saying about the non-responders, and you don't really believe that there is such a thing as a non-responder. I think in adults, we're often maybe dismissing non-response a bit too early in patients. And I'm just wondering if your definition of non-response includes lack of a clinical response, or is it lack of a fetal hemoglobin response?
Yeah, so on the fertility, I think I alluded to it, but the French group actually has had pretty positive data. A couple of things published in Blood last year that showed that positive, that there doesn't appear to be significant deficit. In women, it's a bit controversial because the comparisons have been in treated versus untreated women, and those who are untreated probably have a less severe phenotype. And so I think that healthier body, healthier organs will be better for the long term than untreated sickle cell, but still to be determined. I think non-responsiveness is related to both clinical and laboratory response. Laboratory response is much more objectively measured, and I think there's a variation. Some people are robust responders and some are not. But I think adherence is important and dose is important. So if for someone that was a non-responder, if we could have them do directly observed therapy at a good dose for 3 months and they would still be a non-responder, I would be surprised. But those are my thoughts.
There are a couple of questions in the chat. One is considering the pharmacokinetics, would twice daily dosing be more beneficial than once daily?
Yeah, so technically the half-life is 2 to 4 hours, so really twice or even 3 times daily would maybe make more pharmacokinetic sense. But we know how difficult it is to get the patient to take it one day. Some people actually argue that if you, in the early studies, even thought about giving like bursts of it, where you'd give super high doses once or twice a week, and just again to improve adherence. So twice a day might be better, but once a day is pretty good and is easier to deal with from an adherence standpoint. So I don't think we're probably going to go back to a different dosing regimen at this time.
And then another related question in children. I think this applies in the UK. The constraints with respect to pediatric appropriate formulation. How you overcome that in your practice?
Yeah, so we use a lot of liquid hydroxyurea, which is compounded here by our pharmacies, which allows for dosing, in 10 or 20 milligram increments. I don't know if you in the UK, I know the rest or most of Europe uses Cyclose, which has a 100 milligram tablet, which gives a little bit of flexibility in dosing. As we're thinking about dosing in Africa, we basically are only going to have access to 500 milligram capsules, which you can open and do different things with children. And in those cases, when you only have higher dosage, you kind of need to be creative about a weekly dose. And so, every other day, or 2 capsules on this day, 1 capsule on that day, you have to be a bit creative. Liquid hydroxyurea for young children is the best, but I know it's challenging in many places.
And then just one from the chat, and then we'll get back to the rest of the audience. Any concerns about the risk of AVN in patients on hydroxyurea? And I guess this relates to the fact that there have been some observations in patients with high hemoglobin F levels, particularly in the Middle East, who have a high incidence of AVN of the hips.
Yeah, it doesn't appear so. And again, I think we really just have a growing young cohort who's going to have super high levels growing up, and time will tell. I don't suspect that will be the case again, I think, but time will tell, I think. No signal so far.
Thanks. And Lena Karnik.
Hi, thank you so much for the chat. I have Dan Dexter here with me, one of our aspiring young hematologists as well. This is you alluded to Google in your initial slide, and I totally agree. But I also feel like there must be a huge impact of social media and what patients and their families sort of exchange on social media, their chat. We certainly hear from our patients in the UK about chat from the US, and it's sort of how do you this may be a bit of a wide general question, but in terms of patient engagement in all these trials, I think that must be so key. We're not doing these hydroxycarbamide, hydroxyurea dosing trials, but how have you gone about facing this and dealing with these challenges?
Yeah, I think trying to be So you're right. Whether it's Google or Facebook groups or just other patient groups in the community, there's all sorts of discussions. Some of them are quite alarming at what's discussed out there. But I always try to ask about what's being said and what they have concerns about, because some of these, we see this with the COVID vaccine. We see this across all of healthcare that crazy things are heard, and you just need to address and respect their concern and not just tell them they're crazy, and sort of talk to them about it and tell them what we know and try to develop a relationship. I think various aspects of social media can be impactful too. I've over the last year or two used Twitter a bit to advocate for things around sickle cell disease and to help, again, clarify misperceptions or to simplify research findings. But I think the biggest thing is just having clear communications and listening to patients and hearing their concerns and addressing them instead of sort of poo-pooing them.
Shabana Chakravorty.
Hi, thank you for the excellent talk. My question was about hemoglobin SC disease and the use of hydroxyurea in that context. I know that sometimes where it's very difficult when they've got a we know you mentioned high hemoglobins before, but I know that there is quite a lot of practice. The French frequently will venesect their SC patients if it goes a little bit high. We've not yet had anybody who went to a point where we think that it's dangerously high and we need to venesect, but that's often something that is brought up. And so I've got two questions really. One is to do with use of hydroxyurea in SC patients and how you deal with it. Do you have to venesect them if it goes really high, like 13 or 14? And the second question is to do with headaches. We have a bad press about headaches and hydroxyurea here, and I don't know whether you see that often. And it's really difficult to undo the damage that piece of information does in patients, especially teenagers who would have headaches for other reasons, but it fixates against hydroxyurea. So two questions: SC and headaches.
Sure. So for SC, we don't. Unfortunately, there's not great evidence. I know there's been some efforts to try to do some trials in SC patients, but we don't really know. There's been experience and anecdotally, and I'm sure you guys have the same experience, it works for some patients clinically. It doesn't really have the same hematologic responses. It doesn't really raise your MCV or fetal hemoglobin, but when I talk to patients about using it, I use it as a trial clinically to see if they feel better or not. And unfortunately with hydroxyurea, really any of the drugs, we don't have a great treatments for SC patients right now. I think hydroxyurea is worth trying, but I haven't had cases where we've had to venesect or phlebotomize patients because of high hemoglobins. I sort of would wait for, so the same way I would treat a non-sickle cell patient as a hemoglobin of 19 or 20 or 18, you sort of, if they're symptomatic, then maybe you would do something, but if it's just a little higher than normal, keep an eye on it and watch it closely. But I would probably only recommend phlebotomy if someone had symptoms like headache, taking to question number 2, which I don't have clear answers for. I think, whether it's headache or belly pain, and everyone has symptoms related to any medicine they take, and I don't think hydroxyurea is known specifically to cause headaches, but patients have their experiences. And again, I think it's important to try to listen to the patient, maybe give them a try, have them document how many headaches they have when they're taking hydroxyurea, then to have, these are things I'm sure you've tried, and then to do that after stopping hydroxyurea and see how it goes. But there are some patients who, for one reason or another, whether it's, some, people who are maybe taking a shower and they get a little bit of hair in their hands as they're washing their hair, and then they think hydroxyurea is causing them to lose their hair, and so they'll stop. And so it's trying to have a conversation, but certainly adherence and barriers like that are really challenging.
There are just two more questions, Pat, if that's all right. One from Mercy Ibidapo. Mercy, are you there?
Oh, I'm here. Oh, hi. Thank you very much for the lecture. Can you hear me?
Yep.
Yeah, okay. I'm just wondering whether there's any genetic determinant that in relation to response to hydroxycarbamide.
Yeah, it's a great question. We don't, we're trying to explore that still. So we really, frankly, 30 years later, don't even understand how it induces fetal hemoglobin. We know the enzyme it inhibits. We know that it does induce fetal hemoglobin, but the exact mechanism is not very clear. We've tried to look, or people have tried to look at genetic determinants, and there's none that have been clearly identified. There are genetic determinants of fetal hemoglobin level, like BCL11A and others, that affect your baseline level of fetal hemoglobin, but don't seem to affect your response to hydroxyurea specifically. So we don't really know very well who might respond or not respond genetically, and there really haven't been any great genetic markers of dose or any of that.
Any studies relating to the XMNL gene?
So similar to the BCL11A, I think any of these known genetic modifiers of fetal hemoglobin will affect your baseline level of fetal hemoglobin, but won't affect the delta, the change really. It's not going to affect it doesn't affect hydroxyurea. You might get a higher level of fetal hemoglobin after hydroxyurea, but really only because your baseline level was high.
Okay. Yeah, thank you very much. Thank you.
And then lastly, Toyin Lythe from Luton.
Yeah, thank you very much for that talk, and you gave a lot of support for us in how we address certain queries with our patient groups. But again, just about side effects and any advice or any experience of your observation of this. So yeah, in our local hospital, we're increasing our uptake of the use of hydroxycarbamide. But I'd say over the last year or two, I'm seeing a number of families who are wanting to stop because of side effects such as nail discoloration, hair loss, and then testing out, that we reduce the dose, those symptoms improve, or trying to stop it. Then we try it back on, and the symptoms, increase, and then they just make a decision. They don't feel that is it's worth it based on the psychological impact on their children. So yeah, that was my question to you.
Yeah, adherence and perception of the impact of side effects certainly is important. And again, I think discussing these things up front is helpful. I try not to have patients have surprises. The nail discoloration thing is really a cosmetic thing only, and it doesn't cause any problems. But for some people, it's a cosmetic thing is personally or psychologically problematic for them, and it's a continued discussion. And there are some, like the ones I'm sure you're experiencing, who it doesn't matter. They don't want that to happen, and they won't take the medicine, and that's it. In which case, it's good that we now have other options for these patients that are developing with time. Not everyone's going to want to take hydroxyurea. The hair loss thing is tough. It probably does it to a small extent, but it's another, like I sort of mentioned before your question, once it's in someone's head, if they notice any hair loss or they sort of think a lot about their hair, I think, if they're taking a medicine that might do something to their hair, and it depends on how significant it is. I don't think it's probably very dose related, to be honest. It's either going to happen or it's not. I don't think that changing the dose up or down is probably going to make a big difference. But it's kind of having a discussion of pros and cons and trying to discuss with them. We have psychologists as part of our team too, to help them think about these things a little more carefully perhaps. But yeah, these are barriers that I think we don't have clear answers to, that we still try to work with.
Thank you.
Okay, well, if there are no further questions, just remains for me to thank Pat on behalf of all of us for making the time to speak to our network today. It's a highly informative talk, and we hope to welcome you back at some point in the future to hear about the further studies.
Yeah, I appreciate it. I request the next one is in person. Dan said he would take me to Liverpool then, so I'm hoping to make it over there in person someday. So.
Good. Okay, many thanks.